All right, good morning. Welcome to Pediatric Grand Rounds. My name's Mary Leonard. I'm chair of the department and very excited to welcome you to today's Grand Rounds for many reasons, as you will hear. But as always, we start with the land acknowledgement shown here, as well as a reminder of the text code to get your CME credit. And that will be in the chat for those many people who are joining us online. Very excited about today's speaker, but I also want to call your attention to the incredible lineup coming up. Danton Char in anesthesia, who does really wonderful work in particular in palliative care in children with complex congenital heart disease, but also going to talk to us about ethics research, empirically studying ethical challenges to inform policy decisions in care of children with complex illness. And some of you may know we're about to create a division of palliative care within the Department of Pediatrics, and Danton's going to be a wonderful partner in that work. And then winter break, wishing everybody a very happy holiday season or a restful winter break. And then just incredibly excited to bring Daphne here. Daphne just newly joined the faculty in the Stanford Center for Bioethics and within the Department of Pediatrics. Really absolutely world-renowned international thought leader on the intersection between racism and genetics and policy. And as shown here, she's going to talk about social responsibility and the weaponization of genetics research so just a really remarkable lineup. And really all of these people are here on our campus, and bringing them all together in this forum is so exciting. I hope everybody knows about the pediatric internship program at Stanford. This is something that Allison started, bringing in URM, first income or first generation low income families, high schoolers from around the Bay Area. The graduation ceremony this year, I think, was probably the most joyous occasion that that I personally have experienced in my role. It's the 6-week summer research internship for URM Bay Area high school students. And not only does Allison have this really visionary curriculum for the students, but as well for the parents, helping them think about financial aid applications and those sort of things. And so we're looking for mentors. Allison, we've said, make the program as big as we can do it. And so the mentors are critically important. So please consider that. And then also looking ahead to MCHRI, we now have a monthly seminar series, also does the sort of Herculean task of bringing together all the people passionate about maternal and child health across all of Stanford University. We're going to hear from Steve Montgomery and Matthew Wheeler about the detection and diagnosis of Mendelian and undiagnosed diseases through Gregor and the UDN. And then Natalia and Pasquale are going to talk to us about engineering the hematopoietic system to treat non-hematologic disease. We're really proud about that work. And Natalia's in the Department of Peds. And then that time of year to start looking ahead to our 14th annual pediatric research retreat. And I'm encouraging you to think about the call for abstracts. The deadline is January 15th. And with that, we're going to turn to David. So very excited to introduce David. I first heard you speak probably 5 or 6 years ago, and we've been so excited thinking about social determinants of health and life course research. David's an associate professor in the departments of epidemiology and population health and medicine, and then in sociology by courtesy. And as of this morning, I sent the email to get him a courtesy appointment in the Department of Pediatrics. He's the director of the Stanford Center for Population Health and a member among many roles, but also a member of the Center on Poverty and Inequality. The aims of his research is to understand the mechanisms and processes linking socioeconomic disadvantage over the life course. So an area of great passion to all of us with social inequalities in health. His work integrates statistical and conceptual strengths of public health, economics, and epi methods with considerations of the underlying pathobiology of chronic disease. So each and every one of us in our various disciplines in pediatrics can think about what our subspecialty, what the important social and pathobiologic determinants of life course are relevant to our subspecialties. His NIH Career Development Award from the National Institute on Aging, so that end of the life course spectrum focused on how spatially patterned social and physical exposures early in the life course impact social inequalities in health. We are so excited about leveraging his expertise as we conduct large-scale pediatric studies in PedsNet, more to come on that, and other opportunities. And especially for our fellows who are now, we have increasing funding and opportunities for our subspecialty fellows to do master's degrees in clinical research and epi, and David teaches the life course program there. So another great partnership. So welcome, David. Thank you.
Thank you. Thank you so much, Marian. Really excited to be here today, especially here at this hospital where my kids have received such excellent clinical care over really the last 10 years. It's a real honor to be here speaking with you today. So I think at the end of the day, we have a lot in common in terms of thinking about child health development over the life course. But my work, as Mary mentioned, is really kind of zoomed out and thinking about the things we do as a society or the things we don't do as a society that over many years and potentially over generations really have a big impact on health, both of kids and folks as they get older. So I want to talk to you about this particular project that I've been working on for a few years with some colleagues who I'll mention. Really looking at a particular social policy, a big social policy, and what the effects have been over time. And this is really work in progress. I'm going to talk about 3 papers here. So hopefully, a bit of a deep dive into a little bit of data and methods, but at the end of the day, kind of overarching to some of the evidence we're having about this exposure. So I want to talk about three kind of aspects of the background that this work is built on. And the first is the work of David Barker, which, there's been interest in sort of early life conditions in utero exposures really for over a century. But, in the 90s, the work of Barker, talking about in utero exposures, he was particularly focused on nutrition, really got a lot of interest and enthusiasm for this type of work. But really, he was coming from a pretty physiological perspective. A second piece of evidence that I really draw on and build on are also a lot of the work done on early childhood education and the influences in health long term. So this includes the obesitarian studies, really amazing work building on small randomized studies where then folks have been followed up for health long term. So a lot of really compelling evidence, primarily in populations that are very poor or excluded from a lot of resources in society. And they've been really small studies. I mean, because they're randomized trials of interventions, extremely powerful study design, but, you have 100 people, 150 people. And so kind of building evidence, I'm interested in kind of expanding on that and building evidence in sort of larger data sets for what we might see. And then there's a third perspective, which is probably closest to what I'm motivated by, which is thinking about generational interventions and the role of socioeconomic position and education and poverty over time in child development as people age over the life course. So if you haven't seen this excellent paper from a few years back in Pediatrics, there's a really nice overview of a lot of this work and some nice kind of conceptual models. So looking at this figure here, you can think about a first generation of helping parents in their lives, the work that they do, help parents as parents, improving child development, and then economic gains from that over time. And they extend this even further in this paper and argue about across generations, across 3 generations, how thinking about socioeconomic status, the influences on health, which in turn influences socioeconomic status over time, influencing health, and this sort of process over time by which we can build population health, create healthier communities, and really improve the health of patients. So I'm super motivated by this work, but I think the one reaction that I've seen from a lot of people, and honestly, the reaction I've had a lot of times is like, most people agree with this. Most people think it makes sense. And it's kind of like, wow, that seems overwhelming. That seems complicated. And how do we even do that? How would we even think about changing SES? These seem like such kind of intractable problems. Poverty's been in the US for many years. What can we really do about this? The other kind of flip side of it is a lot of times people will talk about, all the bad things that will happen. Like, this is bad, this has been a bad policy, really negative exposures. So I think when we think about this, I'm really interested in what have we done in the past? How does that inform what we could potentially do now to actually change these things? And as you think about this sort of G1 SES here, which I'm going to kind of focus on today as like this New Deal exposure, thinking about a change in that, how could this potentially resonate and actually change a lot of these other things in these streams over generations and over time. So that's what I'm going to focus on today. So, this is one example. There's a few other policies that I'm working on. There's a lot of interesting things to study, but we really gravitated towards the New Deal. And one of the largest programs of the 20th century in terms of people affected, in terms of the size of the policy, and something that the way how old people would be who are affected as children, you're going to see potentially differences in mortality today. So we wanted to look back to one of these policies and see if there was a way to look at the long-term effects of that. So it was a very large policy, approximately 3 million people employed at its peak. There was over 9 million people who received jobs during the Great Depression. So this was FDR's response to the Great Depression. And I enjoy talking about this. And over the years, I've been learning a lot about it. And I could do a 2-hour talk just on the history of the New Deal, but that's not why we're here today. So I'm going to be talking about the health influences of that. Here's just an example of sort of the scope of the New Deal and all the projects that happened as a result of this employment across the country. So there's this really cool kind of crowdsourced website run by folks at Berkeley called the Living New Deal that talks about just all those projects that are around. So I just want to give you a scope, kind of just a super brief background on kind of the size of this intervention. So here were the type of jobs. Again, there were like 8 million people employed, so around over the course of the Depression, around 6 or 7% of the US population. A lot of it was for infrastructure, highway, roads, street repair, but a lot for also education. So a lot of teachers were hired with the program, and then other sort of sewer and infrastructure projects. So we have a bundled exposure here, but I think it's sort of a realistic exposure as we're talking about things today. So it's both employment and also infrastructure that was needed at that time. So we can imagine, obviously, the discussions now about the new types of infrastructure we need for climate change, but not something completely different than what we're talking about today, obviously. Another example of a lot of school lunches served, really, really interesting programs. I think right now we're talking about, today I'm talking about this exposure as a whole, but as we go forward, think about some of these specific type of things, like how much did some of this nutritional stuff matter? How much did some of the malaria eradication matter, for example? So we're diving into those specific projects as we go on. Just to put this in the context of some of the current things, I think one of the tricky things with if you're doing life course research and you're looking at something that happened 80 years ago for older age outcomes today is how relevant are those exposures? They're obviously completely different, a very different context now. But I just want to say that the WPA and the amount of spending for that program isn't completely out of scope of the type of infrastructure programs and social spending that we're talking about today. So in current dollars, actually the American Recovery Act under Obama in 2009, was about the same amount of money as the WPA, and that was in a much the U.S. population, was much smaller back during the WPA as well. The recent Inflation Reduction Act, was on the scale of this. It was cut back over time, and some of it was on deficit reduction, of course, but the sort of infrastructure money was around 330 billion. So still things that are on the scope. So the point here is that even though this is a historic program, things were very different in the Depression. I think we can start learning from this about what the effects of doing something similar today might be. So one of the big things that comes up is how do we even study this? And so there's kind of two primary ways you'd study early life exposures. The first would be a birth cohort study. We know those are extremely useful and helpful. They're also very expensive, and we've obviously had some difficulties getting those funded in the U.S. The other thing, of course, is if we started it now, of course, it would take many years to see those effects in older age. The second approach is asking questions about childhood or asking questions about early life experience, which is another great strategy. There are sort of some methodological issues. There may be reporting bias. There may be a lot of things that people don't remember. So still a good approach, but some limitations. There's a third approach that I take in these studies, which is individual level data linkage. So what we're going to do in all of these studies is we're going to take current cohorts and link back to 1940 census data to find out what was going on in their lives back in 1940. So this has been a collaboration with Ram Abramitsky here, who's a historical economist at Stanford, and Rob Warren and Yvonne Roberts at University of Minnesota. And what you need is, if you have a current data set and you have their name and what someone's name was in 1940, birth year, state of residence, you can do linkage back to that data and find out a lot of information from the 1940 census, now the 1950 census, prior census. So we can start to construct, even without asking any questions, without really collecting any new data, a lot of exposures over the life course for a cohort where we have outcomes on them today. So what kind of information can we get from the 1940 census? For the purposes of the studies I'll be talking about today, we can find out if that person was working for pay or profit in private or non-emergency government work during the week of March 24th to 30th. And if not, were they doing public emergency work? So were they benefiting from the New Deal? Or was this person seeking work? So we can find out a lot was going on in this household. What we end up doing as an exposure, so actually, if someone received unemployment, this is going to be pretty confounded by their circumstances. So during the New Deal, it was people who were unemployed, people generally in worse economic circumstances who received these jobs, which is exactly what you want. But then this really kind of confounds, because of the selection, confounds our estimates. So what we're going to do is we're going to look at the amount of employment in small areas, and then control for individual characteristics and control for the characteristics of those areas. So we're going to be looking at small area exposures. And this ends up having a lot of variation around the US. Some places received a lot more jobs than others. And so we're going to be using that exposure of interest to test what the effects of this policy were. So now I'll get into the three papers here. So the first paper is with, actually all these papers are with my colleague, Sepideh Modric, who's a health economist at San Francisco State. And we've been collaborating on this project together for the last few years. So this paper just came out this summer in Demography, if you'd like more information on it. And it's looking at the long-term effects of the New Deal relief in the Wisconsin longitudinal study. I don't know how many people know about the Wisconsin longitudinal study, but it's a really rich data set. So it's only in Wisconsin. I'll get to national data later and a few of the other studies, but it's really well-characterized data on a lot of aspects of development over time from high school on. It's also has the advantages because they have a lot of information on folks and they have last names during high school, they're able to do really high quality linkage. So with changing names among women or anyone who changes their name over time, the linkage becomes more difficult. So there's ways to get around that in some ways, but in the WLS have really good data on that, and then really rich data over time. So this is a sample of, and the timing of it was really perfect for our analysis because this was a sample of 1/3 of all high school seniors in Wisconsin in 1957. So they were all born right around 1940. So we can look at the 1940 data, look at some of these exposures and what the effects were on their development over time. It's a sample size of around 10,000 individuals. And again, just want to come back to it and make sure it's clear. So there's something called the enumeration district. That's a small area that was available back in 1940. So the kind of, if you're familiar with some of the census geography now, like block groups or census tract, that's sort of a more recent development by the census. And so the equivalent of small areas back then were the enumeration districts. So it's something kind of like bigger than your local neighborhood, but really a pretty local measure of employment from the New Deal that we use as our exposure of interest. So here's a map of the percentage of the population receiving relief by county across the US. So this is what I was getting at. There's a lot of geographic variation in where this funding went to, which is how we sort of estimate our effects of interest. And then in Wisconsin, the darker was sort of more jobs from the New Deal. The lighter colors were less jobs from the New Deal. So we use that as our exposure of interest. So our study question here was, what are the enduring consequences of the childhood exposure to local area New Deal emergency employment work relief activity on outcomes spanning the life course? So this is a control on covariates strategy here. So we're going to control for a lot of individual characteristics and characteristics of those areas to try to make an actual comparison of what are the effects of New Deal spending. There's some other sort of instrumental variable strategies we're taking that I'm not going to talk about today, but just so you're aware of those warnings, this isn't a randomized experiment. I'm not talking about a super good instrumental variable, but we're really doing our best we can with the data. And we did a lot of exploration. There's actually really, really rich data on individual level confounders and area level confounders that you can actually control for. So there's literally hundreds of characteristics of these areas. And we can do some sort of data-driven models and a lot of kind of fancy statistical stuff to make sure we're really trying to do our best job controlling for confounding. But again, it still is a controlling for variable strategy here. And I won't repeat that. That's the case for sort of all three of the studies, just so you're aware, and we can talk about that in Q&A. So what was different about sort of these areas? So we divided the New Deal sort of expenditures and the New Deal employment by area across quintiles. The Q5 is sort of the most employment. Q1 is the least employment. One of the key things to look at here is sort of the characteristics of those areas. So if you look at the average home value over those, you can see that the most funding and the most employment was going to those folks living in the poorest areas. So again, if we don't control that out, this will be confounded. It'll just kind of look like things are worse. But you do see that the funding going to those areas that had the greatest need. And so we'll control out for that in the analysis. And so here's what we found. I just picked out, there's a number of health outcomes later on that were sort of null in this analysis. And I'll come back to that in some of the papers. But what we really found strongly associated, or I should say moderately associated, but consistently moderately associated with exposure is educational outcomes, income outcomes, and sort of test scores and IQ tests over time. And so I'll walk you through this a little bit, but that's the sort of overall summary of the findings here. So this is compared to, if you look in the red highlighted area, this is compared to Q1 is areas which had the least emergency employment. And then we go up to Q5 with the most emergency employment. And this is, we have people were higher in rank in their high school graduation, in standardized IQ, whether they received a bachelor's degree or not. And then their income over time ended up being higher as well. And there was a pretty, I'll talk about this later in some of the other studies, but there was a real, it kind of, in the lowest areas, you didn't see it. And then it was sort of a threshold effect to sort of the middle. So all of those areas, really the upper half of the distribution receiving more of these jobs seem to have these better developmental outcomes. And there's further details in the paper that you can find. So coming back to this sort of figure here, we found that, if you think about this G1 SES in this conceptual diagram as being something that we can influence by the New Deal. So we're considering employment as an aspect of SES. This program's providing employment for these areas where people live in. This is then what we see here affecting the G2, so their kids who were born right around 1940 in the WLS, influencing their education, their income over the life course. So we kind of document specifically this policy in this first, and then we'll get to these sort of other arrows in the second two papers. So this next paper was with some colleagues, Mark Lee, who's a doctoral student at Minnesota, and Amal Haradi, who is a postdoc here at PHS and who is now doing excellent work at Mathematica. And here we looked at national data. So we took a very similar approach to our exposure. We looked at sort of more focused on cognition in older age, cognitive decline. And looked at what the effects of this would be in national data from the health and retirement study. So again, kind of coming back to this sort of conceptual diagram and what we need to really control out for here. We have the emergency employment coming from the New Deal. This is associated with neighborhood characteristics. We know the Roosevelt administration and the local control of these jobs were kind of interested in two things. They were interested in actually, where do we need sewers? Where do we need electrification? But they were also driven by where are jobs needed. So it was both relief and recovery. This was also associated with family characteristics. We know the households that were more in need were receiving more jobs. So we want to control out for this, look how this affects adult characteristics, and then affects cognitive function over time in the HRS. So the health and retirement study, again, this is kind of to some of Mary's points on the introduction. This is an aging study. I mean, it's called the health and retirement study. People are sort of recruited at age 50 and above. But now we're able to sort of extend this data by doing this linkage back to the 1940 census to include what's going on with people early in their life and to kind of turn this into a bit of more of a life course type of study. So there's a baseline survey in 1992. So in our studies, that's focusing on folks born 1931 to 1941. There's other kind of supplemental samples. But again, this is kind of the key time frame for thinking about these exposures then in this birth cohort, kids that were from sort of age birth to age 10 and would have potentially had parents in the household or in that area employed by the New Deal, and then looking at how that influenced health over their life course, and in this case, cognitive function and cognitive decline in older ages. So the sample was linked to the 1940 census. The linkage rates were less strong than in the WLS, but we still had around 60% linkage in this data. And we restricted to individuals 17 or under during the 1940 census. But the bulk of the data was sort of age 0 to 10. Sample size was pretty small, around 5,000 here. But we had pretty reasonable measures on cognitive outcomes from the HRSDUs. And again, this exposure is employment in this sort of small enumeration district areas. The study question, did exposure to the WPA employment at the small area level influence cognitive function in late life? So again, we really focus a lot on the control variables here. And we have good data on that from this individual level study and from the US Census. So we can control out the percent of, so we control for in the areas, percent of non-Hispanic white, percent foreign born, age, and a number of other characteristics. And I won't show this sort of details. We also did a lot of robustness checks to sort of whether we can kind of eliminate our effects by controlling for a lot of other variables, and results do hold up very strongly. So I'll take a minute here to talk about some of these kind of two main models for our analysis. So the first model, again, this is Q1 is the lowest, so the least employment in that area, up to Q5. This is in standard deviations of cognitive function from this 27-point scale. And so in the first model, which doesn't control for the characteristics of areas or characteristics of households, you really see no effect. So nothing going on. But the point here is that we really need to control for those characteristics of areas because it's areas that are most in need that are getting more of the employment. So when we actually control for area characteristics, then we see this influence sort of, so this is in model 2. So in the Q2 of 0.017, Q3 0.092, et cetera. So this is around close to 1/10 of a standard deviation change in cognitive function with a quartile difference in employment. So it's, again, this is where you can see a little better the threshold effect that I mentioned in this other, in that in the lowest 2 quartiles, we don't see too much going on. And then once you get to quartile 3, about a middle level of spending, you see something between 0.06 and 0.09 of a standard deviation difference in cognitive function when there's more employment. And we show a few other models in the paper, whether controlling for a few potential mediators, other things, and the results are fairly consistent across those levels. So coming back to this diagram, this is where then this work kind of extends. If we think about cognitive function as one of these key aspects of older health, we're linking what's going on from this G1, what we linked together in this first paper, now to thinking about health in older ages, and we're really expanding this work now to focus on a lot of chronic diseases as well. So in the third paper that I'm going to talk about now, this is backing out even a little more, taking a slightly different approach. Instead of doing individual linkage, we're going to think about the characteristics of counties, and then what happens to the mortality in those counties over time. So there's been a lot of interest and discussion over the years about levels of mortality, levels of health, and how they vary over the United States. So a lot of geographic variability in life expectancy and quality of life. And we're going to think about that in terms of how much of that is driven by what happened 80 years ago with the New Deal. So we're going to think about this now, shifting from the individual linkage to thinking about areas and places. And instead of doing this in just a purely descriptive way and saying, you know, people live longer here as compared to there, in a current sense, we're going to really link this back to the past, link this back to history, and what happened with the New Deal, and how that may be having an influence over what we see today and the health inequalities that we see today. So this is work led by Yvonne, who's a research scientist I've been working with at PHS over the last few years. So in this, we're going to be more explicit about race, and we're going to focus in particular on the exclusion from New Deal jobs for African Americans. So this is a quote from a newspaper, an African American newspaper in Cleveland, that says, and I'll just read this highlighted quote: "We have good grounds for the charge that there's widespread and deliberate discrimination against our people." So there's a lot of discussion at the time about how in different areas of the country, New Deal jobs were not being given to African Americans. And this was because of the way the program was designed. So the Roosevelt administration allocated funds out to different states, out to areas, but then there was local control at a small area level of who was given jobs and who wasn't given jobs. And so we switch here from looking at this overall exposure of, in this paper, from the overall exposure of just employment from the New Deal to differential employment between Blacks and whites as a measure of structural racism from this specific policy, and look at how this might have influenced health over the long term. So we came up with this metric of public emergency work. And as a reminder, again, this is work in progress, so not the final thing. So in particular, very interested if folks have feedback on this sort of third paper that we're working on now. So this is the metric, and let me pause here a minute because it's a little bit complicated, but hopefully you can get the kind of intuition behind it. So we wanted to get a sense of a measure that got at how much was the need being met, the employment needs being met for African Americans as compared to whites in a particular area. So what we do, and again, this is taking data from the 1940 census, but at the county level, Black in public emergency work as compared to the denominator of Blacks in public emergency work with African Americans who are unemployed. And then that's the numerator, and then a denominator is the same thing for whites. And so we're thinking about this ratio of, if you think about it's a little awkward to describe, the denominator in the numerator, what that is a measure of the need in the area. And then in the numerator is how much that need was met, and that for African Americans versus whites. So I'll let that soak in a little bit. Oh, everyone understands it. You guys are good. You guys are good. So, and then here's a distribution on the right of what that looks like in counties in the US. So that little line there is if there was like exact equity in hiring based on the need in areas. So to the right is actually where counties provided relatively more employment for African American people, and for white people on the left, if white people receive more jobs on the left of that dashed line. So we can look at the variation, not in the whole country. So we limited this to states with sort of a reasonable number of African Americans in the state. And you can see this ratio. So if it's above 1 are the kind of light red and dark red colors, below 1 favoring white, so the dark blue and light blue. So clearly this sort of general geographic variation to the north and the south. But what I want to point out here is that even within the south and within the north, there is variability there that we can look at. And so especially if we control out for state fixed effects, which we're working on now, you can look at that variability and not have it be just sort of a north and south effect, although it's also, I think, interesting to not condition that out. But this is the exposure we're going to look at for this final paper here. So looking at what are the effects on long-term mortality, or more accurately, I think I should say the association. So let me reverse and erase that effects thing, the effects word. What are the associations of this difference in hiring for New Deal jobs with the overall mortality in those places over time, looking at those sort of long-term effects there. So the data we use is pretty simple. It's mortality data for counties over time. We have one analysis that I'll show that goes back farther, sort of from mortality data from 1980, but we're going to focus on this sort of more recent data between 2000 and 2020 for 20 years, because we can disaggregate by race, so we can look at the effects on whites and blacks over this more recent time period. And then the exposure data is coming from the census. So the study question: how are county level inequalities and black-white differences in emergency employment during the New Deal associated with the long-term mortality rate? And we're looking between 65 and 85 in those counties. And what we're going to control out for is sort of a commonly used measure that's been used in the literature recently for structural racism, which is the index of concentrations to the extremes, the ICE measure, which has been used as a measure of sort of segregation by area. So we're going to control for that in 1930. So again, I'm not making the claim that what we're finding here in terms of this exposure is completely causal, but we are controlling for sort of a prior measure of inequality, and people are using this as a spatial measure of structural racism. I'll say that I'm not going to show this, but they're correlated at about 0.3. So this measure of New Deal spending, this inequality in hiring from the New Deal, is sort of moderately correlated with structural racism measure from 1930. But also very divergent. So there's very different things going on. They're not completely collinear. So that kind of lends some credibility to our ability to look at this as kind of a distinct sort of policy on its own, separate from that, although part of that continuum in places. And we use a 3-level, multi-level linear model to estimate this. So you have to zoom in on this because we have this with a scale in our figures that's the same across, that we keep the same across groups. So we don't want to do that scale. But this is over time from 2000. And what stands out is this little light. We do quartiles of this exposure of differential. So this little light line that's slightly above the darker line is that quartile 1, which is those areas that are strongly favoring white employment. And we see a mortality rate per 1,000 that's around 1.5 to 2 out of 1,000 higher than those other areas. So we see this higher mortality rate over this period of time, even getting a little bit stronger over the last 20 years. So as a reminder, this is an exposure back in 1940 in these places. We're controlling for characteristic and we've done other models controlling them for other characteristics, and the results look similar, back in 1930. And we see this differential hiring based on the New Deal tracking to sort of these differences in mortality rates today. This is equivalent to an additional 9,000 deaths per year in those counties which favored white emergency employment. We can also look at it disaggregated by gender and race. The associations we see tend to be stronger for men, both Black men and white men. And there's an additional 3,000 deaths of Black men and women per year in counties which favored white emergency employment, even conditional on these other characteristics of the counties. So one thing, actually, here's another, just another slide on this. And this is the data that's going back even further to 1980, but we can't disaggregate by race. And this is with life expectancy, but we see about this 1 year difference in life expectancy between quartile 1 and quartile 5 of this public emergency work and mortality. And so as we look at this over time, and I don't know if these figures of 9,000 deaths per year, 3,000 deaths per year seem large or small to you, but if you think about this sort of one exposure, one policy, it was a big policy, but 80 years ago. And then you think about the continuity of this over time. So this is really per year, right? So you think about 3,000 deaths per year over this period of time. You think about this occurring, to me, this is a pretty substantial association and impactful association from this one very, very specific policy. And again, I think about it as, we're not identifying in this paper something completely causal, but it's on sort of the continuity of these characteristics by place, but it is this really specific policy. So as we come back to this overall sort of conceptual diagram, now we're starting to really link in this third paper overall to what's happening, getting down to potentially, again, this G2 of mortality by place, and just the amount of time that this occurs and continue to influence. So starting to build and put together a story about how very specific things we do and the very specific ways that we allocate resources when someone's a child have these lasting influence potentially on place and on their health over several different generations. And in some ways I've discussed this, even though I said this was sort of something I'd like to avoid. I've discussed this as a negative thing, but I think we can also think about this as a positive thing in terms of this policy and what this policy did for folks who got the policy and for the areas where African Americans received, jobs that met the needs of their population instead of being excluded. And that was really a positive thing for the life expectancy and mortality that sort of endures up to this day. So in terms of summarizing these three papers, the first paper really showed these small area estimates on adult intelligence, more likely to obtain, or the test. It's important to just talk about this as these tests that they did as part of the study. And then folks obtaining a bachelor's degree and they had higher midlife incomes. So really this continuity and this one particular program of employment, again, promoting the socioeconomic circumstances of kids who are in those households. We see these impacts on cognition over the long term, and then this lasting historical effects of place on mortality rate, and compounding the social inequalities in health by some of this federal differential allocation of jobs based on this sort of local control over hiring. So in terms of the overall summary, this is just my final slide, and then really look forward to your questions. This is really, I see as kind of a beginning of building evidence for how these large social programs can influence child development over the life course through this interplay between socioeconomic conditions of the household and health over time. And I think for any year, as I pointed out, any sort of small period of time, the results can look fairly modest. When you really think about this in a life course perspective and multi-generations, can really build to some pretty large influences. So I think really accounting for that when we're thinking about social policy, that's one of the things that really motivates me to do this work. As we see how much this can, instead of making our decisions in the ROI based on sort of 1 to 2 years, really extending this out, and with some of the evidence from these models, really having a much more accurate ROI for resources for these programs and what the benefits are going to be long-term for health. So really appreciate your interest and attention today. And I'm here at Stanford and always available to talk about this. One of my real interests is sort of building all of these studies, working with people to do these studies and mentoring people in these areas. So very happy to talk. Thank you.
Thank you. That was incredible and really thought-provoking. We have a lot of questions coming in from the many people on Zoom. So we'll start with a couple of those and then we'll pass the microphone around as well for people in the audience. All right. I'm curious if policymakers have shown interest in your work. What kind of reactions have you received when it comes to applying the lessons of your work to our current world?
Yeah, thank you. I'll say this work is pretty new. The somewhat similar work I've done in the past has been on the earned income tax credit and the effects on child health and child and maternal health, actually. And so for that, I did receive interest from policymakers, so particularly folks at the state level. So when states were interested in implementing an EITC program, I've gotten, folks have wanted to kind of get summaries of that work, think about it as a piece. So I think, this is always like the evidence is a very little piece of the puzzle in policymaking, but I think it's an important piece. And like, I wouldn't want to live in a society that only used evidence from scientific studies to make decisions. Like I wouldn't want to live in that kind of society. But on the other hand, I wouldn't like to live in a society where none of that evidence is used and it's totally ignored. And I think we're a little closer to that. So part of my motivation is building some of this, talking with people. And the New Deal work is pretty recent. So it's still kind of the great question. It's still kind of a work in progress, how I frame that and how I talk about that with people.
All right. And then the society where the evidence is distorted and misrepresented.
Well, yeah, then there's a.
Yeah. Okay. Thank you for this interesting talk. I wonder how you were trying to get at these questions or these issues prospectively so we can think causally and in more detail.
Yeah, great question. So, one of the things I'm super interested in that I didn't talk about here is what are good surrogate outcomes for some of these long-term exposures. So are there short-term signals that we can use? And we can use studies like this to look at, okay, what are some of the short-term indicators of these policies that then we could look at, that then we can link to longer-term outcomes. So that way we can evaluate policies more closely. It's super challenging. There's like not a solution yet, but I think there's kind of exciting work being done in that area. In terms of sort of causal, I think there's more sort of, one of the instrumental variable approaches that folks use about this is sort of some political instruments. So for folks in sort of swing states, in addition to relief recovery, there was sort of a political motivation for some of this that was sort of less strong, but strong enough to potentially identify, based on states that were close to voting for Roosevelt or voting for Democrats, they tended to get a little more funding. So you can use that as a potential instrumental variable to look at some of these effects.
And then I think sort of a related question, implications for informing prospective research on more recent policies, Johnson to present, and what's your ideal prospective study? It's a little bit of the same theme.
Yeah, I think, no, absolutely. Anything more recent, and obviously a lot of interesting things done in the 60s and war on poverty that there's been a few great studies on, but I think there needs to be 100 times more of those studies to really understand what's going on and what the impacts are. So I think an incredible amount of opportunity to look at things in the 60s and what the effects are on folks now.
All right. Well, one thing I was going to comment is that Lisa Chamberlain has worked with every one of our divisions to really have champions around disease-specific outcomes. And that was going to be one of my questions, but sort of a related question. So you talked about all-cause mortality. Have you broken down causes of mortality by major groups? Cardiovascular, cancer, I'm going to add renal. And do these findings hold for all such causes?
That's a great idea, and we have not done that yet. And as part of this paper, I mean, that's like a perfect next paper to look at what specifically may be happening, to get at the pathways. So, and certainly we have this. It's national mortality data, so we're well powered to look at very specific causes of death.
Yeah, I think where it could get really interesting is race by cause of mortality interactions, given a lot of the disparities in cardiovascular disease and others. Okay, do we have questions in the audience? Oh, yes, we do. Okay.
Thank you very much for this enlightening presentation. I think one thing that always strikes me is if you compare the US to other countries of similar means, we spend a lot less of our social dollars on early childhood. I wonder, are there prospective studies or other, furthermore detailed evidence from other countries that could help address some of the questions that we've been talking about?
Yeah, I love that question. Great question. And I actually took out sort of a motivating slide at the beginning, which was looking at sort of the health in the US versus our sort of comparator countries and where we're really failing there. So, absolutely. I think there's great data from other, and I think to kind of just restate what you said and the way I think about it, if we're limited to the counterfactuals in the US, there's a lot of sort of potential social policies that we just can't even explore because we've never really done them here. And so I think going to other countries, seeing what they're doing, it gives us a wider space of sort of potential comparisons of policy to look at what the influences are. And at PHS, at the center that I direct, we have these close collaborations with Denmark. They have absolutely amazing data there. So there's a lot of really interesting, a lot of other countries, but in particular, like in Denmark, where they have great data and some really interesting type of social policy variation over time that I think we could look at.
Yeah, and I would call your attention to Ananta Dalla's paper recently where they looked at socioeconomic status and hemoglobin A1C in the US versus Germany, and the socioeconomic impact and disparities were much greater in the US compared to Germany and growing over time. So those sort of comparisons are really instructive. Lisa, did you want to add something?
Just your work is one of the reasons I so love being at Stanford. Love being able to think interdisciplinary, and your work in EITC is, some of my favorite ever. So I really love this. And as I sat and listened to all of this, it just brought redlining to mind. And I had never thought about the WPA as another form of redlining, and that the jobs were disparately not available to everyone equally. And I don't know how I missed that. I was just absent that day in school, I guess. But have you thought about looking at that over time and absolutely anchoring it in cause of death? So when we think about the cause of death conditions where poverty gets more into the skin, type 2 diabetes, cardiovascular disease, looking at that with the inflection point of Medicare and Medicaid, which came in the 60s, and how much that could explain some variation or not. And also then how it applies. And have you thought about looking at the same kinds of questions as it applies to redlining?
Yeah, absolutely. And it's great comments, of course. So yeah, on that kind of second part and with redlining, like absolutely, I think this is where the work needs to go, is looking at that continuity. I mean, this is one thing. There's many things that happen, and it can get overwhelming. But I think if you're looking at like the 3 or 4 kind of really influential policies by place, and kind of looking at the accumulation of those, and then absolutely super interesting, I think, to take a positive spin on it and really think about what we can do, how some of the implementation of some of those programs really brought that together. So absolutely looking forward to doing that work, and I'll talk to you more about it.
Yeah, I love this next question, and I especially love that it's coming from Denny Lund, the Children's Hospital Chief Medical Officer. So with the differential implementation of Medicaid expansion under Obamacare in different states, are we able to track the impact on child health and beyond as children grow?
Yeah, absolutely. Actually, I mean, it's interesting that you would mention that, because I am doing work on that now and looking at that expansion and looking at what the effects are on health inequalities in across the life course. So yeah, absolutely can do that. Super important to look at what the impacts of that are.
When you show the map looking at like the differential impact in terms of race, there's a clear like north-south divide. And so then when you globally compare, in the South at this time, I mean, through the 60s, we had Jim Crow laws, we had segregation, all these other major impactors, but there were some of those small districts that were outliers. What happens to the data if you directly compare like neighboring counties, neighboring areas that had similar laws, that had similar segregation? How does that change the impact of this funding?
Yeah, I want to work with on a paper with you on that. It's an excellent idea. I mean, it's a really, in some ways, I don't want to it's a tough decision. Like, do you just kind of control out the effect of the South and set that aside, or do you kind of consider that as integral to what's going on? So that's one kind of piece of what you're saying, and I think like both are useful. I think that continuity that you talk about, which is similar to Lisa's redlining comment, is super important. Like, we're not at all saying like it was this only, like nothing else happened as a consequence of that. This happened to be earlier than a lot of those things over people's lives. but looking at that accumulation matters. And I think it's a super interesting point to say, and a great idea to like compare neighboring counties where, you know, some of the other programs or some of the other kind of the enforcement of Jim Crow, for example, may have been really similar. Other things may have been similar. And then by looking at those fine-grained comparisons, you may be able to tease out specific effects from this policy. So it's a great idea.
I had a related question before we go to the next question. So the excess mortality, I think, was like 9,000 per year, and then you showed the excess mortality among the Blacks. Was there also excess mortality among the whites who lived in these communities that preferentially were giving support to the whites?
Yeah, I'm glad you bring that up because I didn't mention that, but I should have. So, you know, whites also did worse in these areas where whites were preferentially hired, like over time. So it wasn't just that African Americans were affected, but it was worse health for whites too. And there's really interesting work. I'm forgetting her name now, but she talks about like the drain pool phenomenon through up to the current time, where when like integration was happening, you know, she taught so this metaphor, but the reality of like the public pools that were used for Blacks and whites that then were drained and shut down because folks in those areas didn't want to integrate and didn't want to have African Americans being able to use the pool. So everyone lost the resources. So I think there's some sort of interesting examples of those areas where actually whites lost out too, even though obviously African Americans were more affected.
Wow. Okay, next question.
I just had a question a little closer to home. Maybe you could explain it a little, but you showed a map early on where you had the dark areas and the lighter areas. Do you know which map I'm talking about?
Yeah.
And I noticed that California, and I bring this up because we're in California.
Yeah.
I find that there was basically no work, right, in California. None of these public areas, none of these public programs. And is it because the government was very more concerned with putting money into those areas that was important to the government rather than an individual? You know, I'm looking at those areas in farming communities, and I find it interesting. In California, we were a big agricultural state back then too. So how is it that this whole West Coast essentially there's nothing there?
So super perceptive. You got this interesting phenomenon, and it's my fault for not pointing out this map in a little more detail, which it's super tiny that you would never be able to see. So it's my fault for not pointing that out. Like this is earlier on, 1934, 1935. So it's one of the things we're using as sort of a control variable. So it was actually true kind of earlier on in the New Deal, but actually later in the New Deal, there was more kind of funding in California for a few different projects. And if you go to like the map of the Living New Deal, you know, there was plenty of programs, but I would say a lot of the scope was different and smaller in California, where you didn't have as many of the sort of like the big electrification programs like the TVA and sewers and things. So it is true, but it also is not as extreme as it looked in that map.
We were a pretty diverse state, I think, even in you know, the West Coast, very diverse. So it's interesting that we weren't getting money funded.
At least early on. Yeah. No,
just a comment.
No, thank you.
All right. Well, first, I want to thank you for leaving plenty of time for the discussion. And I want to point out that those people who showed up in person get to do a paper with David. So you need to show up in person. All right. David, couldn't be more excited and more proud to have you. And thank you so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.